Hello, my name's Ian McComb. Today we're going to look at the psoriasiform reaction pattern in histopathology. Now, the psoriasiform reaction pattern is going to be seen in those conditions that are part of the mnemonic of the PM's pet, the little cat called Petal. So if we just have a little look at that mnemonic first, PM's pet, Petal, P-E-T-A-L, psoriasis, eczema, tinea, annular erythema, lupus, sometimes lichen planus. The PMs at the beginning, pityriasis rosea, pityriasis versicolor, pityriasis rubripilaris, pityriasis lichenoides. The M is mycosis fungoides. And the little s there is for solar damage usually, because a lot of red scaly diseases in Australia can be simulated by superficial sun damage, particularly SCC in situ, and conditions like disseminated superficial actinic porokeratosis. So what are the features that you look for that suggest it's a psoriatic reaction pattern? Well, this is psoriasis here on the right. There's usually a degree of acanthosis. That's thickening of the epidermis. Let's go back and just have a quick look at the clinical here. I mean, that's psoriasis vulgaris. It's a fairly hyperkeratotic one. You can see all the scale that's there. There's that background salmon red color, which indicates the, there's some dilated capillaries and the like there. The lesions are thick, so as well as the hyperkeratosis, there may well be acanthosis. There may well be proliferation of keratinocytes in the epidermis. So when we translate what we're seeing here to here, there's our scale on the surface. This usually is parakeratotic scale in the sense that there are retained nuclei within it. And you can see those nuclei in here. There's acanthosis here. There's elongation of the retiridges as well. Sometimes those retiridges join up a bit too. They're usually blunt-ended. There's very thin suprapapillary plates. There's often dilated vessels in these suprapapillary plates, and that's what gives you part of the redness that you're seeing here because of the increased blood flow. And the other feature that you'll often see in psoriasis, though it varies from type to type, is infiltrate of neutrophils into the epidermis. Now, that infiltrate here, the perivascular infiltrate here, is usually a mixture of lymphocytes and neutrophils. There's usually not much in the way of eosinophils at all. Sometimes the neutrophils congregate in a little collection in the mid-spinous area here, and sometimes they congregate, I should say, subcorneally. I'm not sure if we can see some good examples of it here. The collection of neutrophils here in the mid-spinous area is known as the spongiotic vesicle of Coggeau's, and the ones that are underneath the stratum corneum are the Monroe's microabscesses. We may see better examples of those later. But there's, the infiltrated dermis here is usually perivascular, superficial perivascular. But these are the major features that you're going to see in the pathology of psoriasis. Now, the other red scaly diseases, the other diseases that are part of the PM's pet, eczema. It'll have some degree of acanthosis, but the thing that eczema has is marked spongiosis, a lot of fluid separating the keratinocytes. Now, you might say that there's a small degree of spongiosis here, but that doesn't put you off making a diagnosis of psoriasis. The other characteristic feature of psoriasis, by the way, is the lack of a stratum granulosum. And you usually have this confluent parakeratosis. In other words, it's running all the way along the surface, and lack of a granular layer. Or if there is one, it's a very minor granular layer. So that's another feature that you look for as well. Now, this is classical psoriasis, all right, with that classical sort of picture. And there are other variations to it. We'll look at some of those variations in a minute. So just to recapitulate, in psoriasis, confluent parakeratosis, Monroe microabscesses, when you've got the little collection of neutrophils underneath the stratum corneum up here. The spongiform pustule of Cojos, when the neutrophils are at the mid-spinous layer. Very much reduced or absent granular layer, dilated vessels in the dermal papillae. The number of neutrophils that you see depends on the type of psoriasis. Obviously, psoriasis goes all the way from a red scaly disease right to a pustular disease. And when you have pustular psoriasis, you've got massive collections of neutrophils under the stratum corneum. And we'll show you that a little bit later. This is just a slide here to indicate some of the things we've been talking about. You can see the level of parakeratosis that's here. That probably better corresponds to that clinical case you were seeing. You can see the thickening and joining together of the retiridges here, the thin suprapapillary plates, a bit more of an infiltrate here. And we're not showing much in the way of collections of neutrophils in that particular picture. So let's have a little look at the next common variant of psoriasis, and that's guttate psoriasis or raindrop psoriasis. This usually follows a streptococcal throat infection, presents as small red round lesions like this. Now, the differential, you can see here, first of all, the level of scale isn't so great. It's still pink, but the level of scale isn't so great. So there's going to be less hyperkeratosis. Still going to be some degree of acanthosis here. The differential diagnosis, PM's PET, psoriasis, eczema, discoid eczema may be a differential diagnosis of guttate, but not often. Tinea, a lot of lesions for a tinea. It would need to be a fairly acute one. Annular erythemas, no, there's no clearing in the middle of that. And lupus is usually in sun-exposed areas rather than covered areas. And if we look at the PMs at the beginning, pityriasis rosea, it's certainly a differential of guttate psoriasis, but usually the lesions clinically are more oval-shaped and they run along the lines of the ribs here. What else? Mycosis, pityriasis versicolor, the fungal infection. It can be, but usually that's on the back and the scale isn't as much. You know, there isn't really much in the way of scale in pityriasis versicolor unless you take a finger to it. Pityriasis lichenoides, it's a different type of scale, a mica scale. It's stuck in the surface of the skin. And the M for mycosis fungoides doesn't present like this. S for solar damage, well, not in that area that's covered, but S can also stand for syphilis. And secondary syphilis is certainly a differential of guttate psoriasis as well. So you've got guttate psoriasis, pityriasis rosea, and perhaps secondary syphilis as your main differentials. Let's see, though, how guttate psoriasis differs histologically from normal psoriasis vulgaris. This is the histology of guttate. So you can imagine one of these lesions perhaps being shaved like this. This is the area of the scale corresponding to this. There's the normal epidermis, and then there's this area here. You can see there's a degree of acanthosis, but it's not the same marked elongation that you get in psoriasis vulgaris. If you look in, you can see that there's quite marked overlying parakeratosis here as well. There are no obvious collections of neutrophils here, though. You can see the parakeratosis up here. There's still a little bit of a granular layer here, but it's a bit patchy. You know, it's lost in areas here as well. Not as much of an infiltrate here in the dermis. And altogether, it's like an evolving form of psoriasis. Psoriasis at an early stage. You've got to compare it with the surrounding skin. It helps to compare with here to appreciate that there is a degree of acanthosis here. Now, the other thing that you'll often see in gutted psoriasis is a little bit of spongiosis, but it's not marked in this particular specimen. That's the thing about histopathology, and you don't have everything in every slide. So sometimes a wee bit of spongiosis in this. The differential diagnosis we said was pityriasis rosea. What is pityriasis rosea like? Well, let's have a little look at the histology of that. This is the histopathology of pityriasis rosea. Now, you look along here, you can see there's a degree of acanthosis here. There's a degree of spongiosis as well. See the separation of the keratocytes here? And look at the little bit of focal parakeratosis that you've got just here, this focal type of parakeratosis. And the other feature in pityriasis rosea is that there's often some extravasated red cells. It's a lymphocytic infiltrate primarily that they have, and it's not a marked one at all. But there's sometimes some extravasated red cells. I mean, there's some here, some of these are in vessels, obviously, but there's some extravasated red cells here too. So the focal parakeratosis, a degree of spongiosis, a little bit of acanthosis, these always help to make that particular diagnosis. That's the clinical of pityriasis rosea on this side. The herald patch, clinically it looks a little bit like a tinea, but there's usually a trailing scale here. These are some others that have just started to come out as well. It's commented here, you don't get a lot of changes in the stratum corneum, but if you get them, it's going to be focal parakeratosis. Little bits of spongiosis that we've shown there. Lymphocytic extravasation into the epidermis, but these lymphocytes aren't abnormal. As against lymphocytes in, say, mycosis fungoides, that would be abnormal. A little bit of extravasated red cells, usually a superficial perivascular infiltrate rather than a superficial deep. So those are the main things, and they're just highlighted perhaps in this image here. A little bit of red cell extravasation, psoriasiform hyperplasia, bit of spongiosis, obviously more marked in that one, lymphocytic lymphocyte exocytosis, and focal parakeratosis, retention of the granular layer in other areas there. If you were to see a fair number of eosinophils in the infiltrate here in the dermis with that sort of picture, then you can get a drug-induced pityriasis rosea. But you're not always going to get the lymphocytes there. So that's pityriasis rosea. It's obviously different from what we were seeing with gutted psoriasis. The next one to look at would be secondary syphilis. How histologically does it different? This is the clinical of secondary syphilis. You can see again, it's red, scaly. There are some necrotic lesions here as well, though it's a bit unusual. Have a look at the palms of the hands, and you usually see the red, scaly lesions there. And of course, you check inside of the mouth and around the anus. But you can imagine someone presenting with red scaly lesions in the trunk, and you're thinking, is it gutted psoriasis, secondary syphilis, or is it pityriasis rosea? And if clinically you're not sure, you do your biopsy. This is what the biopsy of secondary syphilis will look like. Now, let's go in. You can see there's a little bit of thickening of the epidermis here, but what's characteristic of this is this very marked lichenoid infiltrate of cells. And the thing about these cells is they're not lymphocytes or neutrophils, they're in fact mainly plasma cells. 90% of them will be big round plasma cells. And these plasma cells will infiltrate the overlying epidermis as well. It's all of these cells here. They're all plasma cells. And these will infiltrate the overlying epidermis. You can see it's partially damaging the epidermis here. So it's a lichenoid pattern with some basal layer damage as well. There is some overlying parakeratosis here. And that's what can make it scaly. But you can imagine with that damage to the epidermis here, it might be very similar to what's happening with that clinical lesion there, where you've virtually got erosion occurring. There is a type of syphilis called malignant syphilis, usually seen in HIV patients, where these sorts of lesions like this with necrosis are more common. But you can see it's not so psoriasiform, although some cases of secondary syphilis can be, that it's more lichenoid with the infiltrates, mainly plasma cells. There is overlying parakeratosis as well. There isn't the extravasated red cells that you see. So that's the histopathology here. I'm sure if we've got a little bit of a summary here. A little bit of psoriasiform hyperplasia, especially the late lesions. Mainly orthokeratosis rather than parakeratosis. Superficial and deep infiltrate in syphilis, secondary syphilis. It's mainly plasma cells. They may invade into the epidermis. It's basically a lichenoid infiltrate that you in fact can get. A lot of lymphocytes arranged along the basement membrane. A lot of plasma cells that are there in secondary syphilis. And this was just a summary. Patchy parakeratosis, mild basal layer vacuolar damage, as was occurring up here. A little bit of psoriasiform hyperplasia in this particular one. Plasma cells and lymphocytes as the infiltrate, and a pretty dense dermal lichenoid infiltrate in secondary syphilis. So you can see how it's different from guttate psoriasis and different from pityriasis rosea. Okay, PM's pet, look at called petal, psoriasis, eczema, tinea. What about eczema? We've dealt with psoriasis. How can eczema look like psoriasis? Well, the variant that can is lichen simplex chronicus. Let's look at that clinically first. Now, these are examples of lichen simplex chronicus. This is probably a good one here just to look at. It's on the lower leg. It's itchy though. It's been rubbed and scratched. There's lichenification, accentuation of skin surface markings, and thickening of the epidermis. So and there's a little bit of scale there. So if there's thickening, there's going to be acanthosis. A little bit of scale, there should be some hyperkeratosis as well. Color's different, and it's very itchy. Now, psoriasis in the lower legs can be itchy. You can imagine several lesions like this. You might not be sure whether it's psoriasis or whether it's lichen simplex chronicus. So how does the pathology differ? Well, this is a pathology of lichen simplex chronicus. And if you look here, the first thing is, though it's a form of eczema, there isn't a great deal of spongiosis here. You only get spongiosis really in acute eczema. You don't get it in chronic lichenified eczema like this. There is acanthosis. It does have blunt edges to the rete ridges. They do join together as well. There generally is a thicker suprapapillary plate in lichen simplex chronicus. There's also laying down of vertical collagen in the dermal papillae here. And the keratosis that you see in the surface is usually orthokeratosis. There is a little bit of exudate in this one here as well. But it's usually orthokeratosis rather than parakeratosis. And there's a prominent granular layer. So orthokeratosis, prominent granular layer, thickening of collagen in the papillary dermis. There's not the neutrophilic infiltrate that you see in psoriasis. You won't see subcorneal pustules and the like. And there isn't as much of a perivascular infiltrate as well. There's still some dilatation of vessels here, though. But you can see how they're generally surrounded by a lot more collagen in that papillary dermis than you would see in psoriasis. So these are the major histological features that you see in lichen simplex chronicus. versus psoriasis. Let's just go back to the psoriasis, or the section in here, sorry, on lichen simplex. So there's not a lot of spongiosis. There is the prominent psoriasiform hyperplasia. You've got quite a prominent granular layer, compact orthokeratosis, that vertical streaking of collagen in the papillary dermis. So those are the major features. Now, the more chronic the process is, the more psoriasiform the changes are going to be in the epidermis. But generally, psoriasis isn't itchy. If you've got a really itchy, thickened area, it's much, with scale, it's much more likely to be lichen simplex chronicus than it is to be psoriasis. And this was just another example here, the slight dermal infiltrate, vertical collagen, elongated letty ridges, blunt edges, joining together of letty ridges, mainly orthokeratosis though, and hypergranulosis of the granular layer, So that's how lichen simplex chronicus should look versus psoriasis. Next condition, PM's PET. We've done psoriasis, we've done eczema, at least lichen simplex, and T for tinea. It's a red scaly disease as well, but it usually presents with some annular clearing. The scales usually all the way around to the outside of the periphery, as against the trailing scale of pityriasis rosea. That one's usually not difficult to make a diagnosis clinically. If you are going to biopsy this, you should biopsy the edge here. Don't biopsy the middle here where partial clearings occurred. The fungus will often remain in little follicles and give you a central area like this. But if you do a biopsy of a tinea, how might it look like psoriasis? Well, let's have a little look over here. You can see there's a degree of acanthosis here. There's some overlying keratin. But it's not a parakeratotic picture you're seeing. You look at this acanthosis, you can see some separation of the cells here. There's mild spongiosis, not much, but there's mild spongiosis, a little bit more here. But then you look here, there's your stratum corneum, and then you've got this little collection of cells under here. And there's neutrophils here. You would need to do a PAS stain to see if there are fungal organisms here as well. But whenever you see neutrophils high up under the stratum corneum, tinea is always one of your, dermatophyte infection is always one of your differential diagnoses. You've also got to consider bullous impetigo, you've got to consider localized pustular psoriasis, and you've got to consider pemphigus foliaceus, because they can all give collections of neutrophils underneath the stratum corneum. So it's the neutrophils up here that really put this into the category of a dermatophytosis. But sometimes you don't see that. Sometimes you really just have to do a PAS stain and look very carefully up at the overlying stratum corneum to see if you can see fungohyphae and spores in the stratum corneum itself. There's usually a stratum granulosum. Not much of an infiltrate here, but fungal infections can be missed unless you carefully examine the stratum corneum. What have we got here on it? Dermatophyte infection involves the stratum corneum because it's made up of keratin. That's what the fungus eats. There is a degree of psoriasiform hyperplasia, more in that one than perhaps in that one. Neutrophils in the stratum corneum, well, we certainly saw that up here. Yeah, always look at the stratum corneum if you're considering a tinea infection. And they're commenting here, you can sometimes get alternating compact and basket weave layers of keratin. Well, I don't think that shows it terribly well, but the compact orthokeratosis would be where it's layered, and then normally you would then get the more open orthokeratosis. and the rete ridges aren't as extensive as you would see in psoriasis, and the spongiosis is often a wee bit more marked. And this is just a summary here. Normal looking epidermis, and that one fungal hyphae with bud forms in the stratum corneum. And that's what you need to look for up there with a PAS stain. So that's tinea, a degree of psoriasiform hyperplasia, perhaps compact ortho, a variation of ortho and ordinary keratosis along the stratum corneum, mild spongiosis, but you need to do a PAS. Whenever you see neutrophils under the stratum corneum, certainly tinea has to come in as part of your differential diagnosis. Next one in our differential diagnosis of red scaly diseases from the mnemonic, PETAL, A for an annular erythema. Okay, this is the most common annular erythema you're going to see, erythema annularis centrifugum. And you can see it's an annular lesion with a trailing scale. And the thing is, these expand slowly over a 2 to 3 week period. They sometimes join up, and then you can start to get some curious cystinate patterns. They're usually not terribly itchy at all. They're fairly characteristic. I mean, the main thing you'd look at that and say, is it a tinea infection? Sometimes resolving psoriasis, by the way, clears in the middle and you've still got scale around the outside edge, but it's not usually the trailing scale that you get here. You could look at it and wonder, is it pityriasis rosea because of that trailing scale? But it's the three things: pityriasis rosea, ESC, erythema annularis centrifugum, and a tinea infection. So, say you biopsy this, you're going to biopsy it. You want to try and biopsy where that scale is as well. So you want a bit of that advancing edge and the scale to see. There are, by the way, two variants of ESC. There's the deep variant that doesn't have the scale and the superficial variant that does. And the reason it has the scale is because of a bit of spongiosis. Now, this is an example, a histological example from past presenter of erythema annularis centrifugum. Let's have a look. What about the scale? Go up the top. There's a little bit of scale there. It's not much. And often it's only at one edge that you in fact see it. And usually it's a parakeratotic scale. There is, though, a prominent and present stratum granulosum. The degree of psoriasiform change in the epidermis isn't great. There's a bit, but it's not marked. What really should catch your eye is this superficial perivascular infiltrate and how tight it is, how well it's localized around the superficial papillary dermal vessels. And if you look in on these, they're all lymphocytes. Lots and lots of lymphocytes around these vessels. And that tight superficial perivascular infiltrate with a little bit of acanthosis, a little bit of overlying parakeratosis is very suggestive of erythema annularis centrifugum. Now, some cases will show more spongiosis than this one's showing. Usually the spongiosis will be in the area where the overlying parakeratosis is, because it's the spongiosis, the change in the epidermis, that stimulates the formation of the keratin. Let's have a little look at what we've said here. I've said many cases of ESA don't have much in the way of scale. You may just get a small area of spongiosis and a little bit of parakeratosis there with that trailing edge. And we call this collection of lymphocytes here a coat sleeve appearance of the lymphocytes. And we've said there's a deeper non-scaling variant, and what it has is a superficial and deep perivascular infiltrate. This was our example here: slight parakeratosis, bit of acanthosis, tight perivascular infiltrate. And this is normal orthokeratosis. Now you can see how you might wonder, okay, alternating ortho and parakeratosis. Could this be a fungal infection? You'd always have a look up there to see if there's any fungal hyphae in the overlying stratum corneum. You might wonder also about Psoriasis rosea. But again, you'd look for some extravasated red cells. But it can be difficult histologically sometimes to separate the two. So this was another example here with a little bit of spongiosis, in this case, some parakeratosis here as well. So there would have been a bit of scale in that particular one. Petal, psoriasis, eczema, tinea, annular erythema, and the alpha lupus. I'm not going to look at lupus as a red scaly disorder. It is clinically, but histologically it doesn't have a psoriasiform picture. There is the rare hypertrophic lupus, but it has a marked lichenoid infiltrate in most cases, and certainly not as much as lichen planus. And there's usually a superficial and deep infiltrate and involvement of the adnexal structures as well. But it doesn't usually come into, significantly come into a histological diagnosis of psoriasiform eruption. Let's look at the other things of the PM's PET. The P at the beginning, Psoriasis rosea, Psoriasis versicolor, Psoriasis rubripilaris. Let's look at rubripilaris first, because it's one that clinically can look like psoriasis, and it may well come in as psoriasis, as in the specimen in the request form. This is how PRP can start first. It starts as follicular papules like this. They're red and scaly, but then they all join up, and you can get a generalized erythema, as in this particular case here. They can present as an erythroderma. The other thing that they usually have, though, later is they'll have marked palmar and plantar keratoderma, and they have a very characteristic feature on the face. We actually might look at some pictures from Global Skin Atlas for this. This is actually a little boy with PRP, which the generalized one, which is unusual. I mean, the vast majority of cases are elderly people. But they present with an acute erythroderma with scale like this, and it usually presents in the face, first of all. You can see the red scale here. It usually presents in the scalp, and it works its way down. And even a child has this ectropion. This is another characteristic feature. But, you know, this may be sent into you as query psoriasis. If we just look at this picture here, you can see the thickening here, the thickening over the knees as well, that looks vaguely psoriasiform. So you may well get a biopsy if this sent in as psoriasis. It's interesting here though, look at this, look at the follicular papules as well. You usually see this best on the back of the neck and sometimes the back of the hands, but this is how it starts, then they all join up like this. So what's the histology look like? Okay, we'll go back to that, but we'll take it on this side. This is an example here. Now, this has been a shaved example. You can see there's a bit of acanthosis there. There's a bit of hyperkeratosis, but if you look at that hyperkeratosis, what you see is this alternating parakeratosis with some orthokeratosis. So marked parakeratosis, a bit of orthokeratosis, a bit more parakeratosis, and is there a bit more ortho? Not as much. But it's usually this alternating ortho and parakeratosis that you'll see in the stratum corneum. No, not a terribly prominent granular layer there, but it's a bit patchy. There will be a granular layer further along. Little bits, but not much. Not the same psoriasiform thickening as you get in psoriasis, but it depends on the lesion that's taken. Oh, that's the other thing. Varying ortho, not only horizontally, but also vertically for the orthokeratosis and parakeratosis. The infiltrate's usually lymphocytic rather than neutrophilic. There can be a little bit of spongiosis. Curiously, in some forms of PRP, there can even be a bit of acantholysis in that condition. Not common, but there can be acantholysis in PRP as well. But it's the alternating, both horizontally and vertically, of orthokeratosis and parakeratosis, a bit of psoriasiform, hyperplasia, acanthosis anyway, mild spongiosis, no neutrophils, usually no eosinophils. So what have we got here? Thin preserved granular layer in some areas, focal parakeratosis, alternating orthokeratosis, sometimes still the psoriasiform hyperplasia with club-shaped ridges, but fairly thick suprapapillary plates. So you should be able to diagnose PRP histologically and differentiate it from psoriasis on these on these various criteria. The other P of the PMs bit, we've talked pityriasis rosea, pityriasis versicolor, pityriasis rubra-pilaris. Now we've done rosea, we've done rubra-pilaris. What about pityriasis versicolor? What does it look like? Well, that's a rather florid example. I mean, it's red and scaly, but you can see the scale's different from psoriasis. It's a much finer pityriasis brand-like scale. You have to often take your fingernail to that to make the scale come up. Now, you still might look at that and wonder, you know, what is it? And it might come in as query psoriasis, query fungal infection. So a little punch biopsy is taken, and this is the picture that you in fact see. Now, looking at this, there perhaps seems a little bit of psoriasiform hyperplasia, a bit of acanthosis, a bit of orthokeratosis here. But if it's pityriasis versicolor, the fungus is going to be yeast form, and it's going to be high up in the epidermis, in the stratum corneum. You can see there's very little in the way of infiltrate around vessels here. So you might look at that and say, look, I can't see anything wrong with that. But whenever you're thinking that way, always have a look high up here. And when you look high up, there they are there. There's the fungal spores. A few little hyphae, but mainly spores up there in the top of, right in the surface of that stratum corneum, orthokeratotic stratum corneum. And unless you're looking specifically there or do a PAS stain, you're going to miss that. So it can be very subtle, the histopathology of pityriasis versicolor. And a PAS stain will certainly help to show this up. You can see how little the infiltrate is, but I mean, you can see how perivascular infiltrate, you can see how little redness there is associated with this. So these were just the details here. This can present as white areas on dark tan skin and red areas on white skin. So you may get even a differential of query vitiligo because it's white skin that you're in fact seeing. And this is the histopathology of the yeast spores in the stratum corneum that we were talking about in the basket weave picture here as well. A very slight perivascular infiltrate. The other pityriasis you might see is pityriasis alba, but again, it's not as white as you would see in vitiligo, but it might be biopsied, very fine scale. This is just a low-grade dermatitis. And so the histopathology of that is a very mild spongiosis, little bit of hyperkeratosis, and normal melanocytes, because remember the differential is going to be vitiligo, but you can still see melanocytes at the derm. But this is another one that can be very difficult sometimes to diagnose. And you always do a PAS to just make sure that it's that it isn't pityriasis versicolor. The last of the M's to look at in the PM's PET is Mphamycosis fungoides. Now it can present early as this type of parapsoriasis, this sort of zebra stripe. You can see how that looks awfully like that pityriasis versicolor we looked at. You know, same fine sort of scale on the surface there. Though we often call that cigarette paper wrinkling when you actually look at that. And this is the larger plaque variant of this. The biopsy of this is going to look dermatitic. The biopsy of that, the thicker one, may show some atypical lymphocytes there. but it's a whole new ball game, that one. And it will take me a little while to be able to show you the ins and outs of all of that. And we'll do that in another webinar a little bit later. So those are the features of early mycosis fungoides, a bit of psoriasiform thickening, lymphocytes, but they're atypical lymphocytes, and quite a lot of lymphocytes too. And they may invade the overlying epidermis and form what are called little pottery and microabscesses, but these are abnormal lymphocytes. They're big in comparison to normal ones. And that's the feature that you look for. But very early on, these lymphocytes don't look terribly abnormal. And the little collections that you may have there may really simulate an eczema. And often this condition is in fact sent back to you as chronic superficial dermatitis. So it's easier to make the diagnosis of early mycosis fungoides or parapsoriasis like this as a clinical diagnosis than it is as a histological diagnosis. Thanks very much.